Thank you very much to all of the organizing committee for the invitation to speak with you all today. I have incredibly fond memories of the conference from the years that I've been able to come, and so it's a real pleasure to be able to talk about some of my work with you today in the context of the broader theme. I will say that it's hard to be the first talk this morning after a wonderful day, and particularly very moving session at the end yesterday, but this will be something quite different for us to focus on. So I'm going to talk today, starting out, I know for some of you may already know this, but with a brief review of what are exome and whole genome sequencing and why are there important ethical issues about returning and offering results from whole genome and exome sequencing. Then I'm going to talk a little bit about what we know about what results people might have from exome and whole genome sequencing, because that really does affect how we think about the ethical issues about what we might offer in return to anybody who has their exome and genome sequenced, especially children. Then I'm going to actually dive into what the ethical challenges are, specifically in the context of pediatric research, because that's what we're mostly here to talk about this weekend. And then give you some data from one of the studies that I've been involved in about what parents think about different sequencing results from exome and whole genome sequencing for their children and what they would want. And these are parents who actually are having exomes for their children done as part of research studies. And at the end, I'll have a few seconds to just briefly kind of tease you and talk about what I think some of the emerging and future challenges are related to results from exome and whole genome sequencing, especially in research, but also in clinical care. So this slide is partly an excuse for me to show you my pretty picture. And I think most of you in the audience probably already know something about genetics, and that's also possibly something that was different from 10 years ago when the conference started. But as you all probably know, DNA is made out of 4 molecules called bases, and they have symbols A, T, C, and G. And they're linked together to make a strand of DNA that forms that famous structure, the double helix, which kind of looks like a twisted ladder. And one of the things that really my work focuses on is thinking about genetic variation, and there is genetic variation among all of us, and essentially genetic variation is largely created by copying errors when DNA is copied in the process of meiosis, and this is an example of the sequence from 5 individuals, and you can see, actually the variant is pointing to the wrong variant, but you can see the green T's and the C's. That is not a variant. The green T's and the C's are a difference where 3 of the individuals are homozygous for a T, the 4th individual is probably heterozygous for a C and a T, and the 5th individual is homozygous for a C. And so that's the kind of variation that we're looking for. Some of that variation is just natural differences between all of us that don't have any changes on phenotype at all, and some of that variation causes different phenotypes, diseases, risks for diseases, and so forth. So we, over the time that I've even been working in this field, there have been huge technological advances that have made a substantial impact on how we find genetic variation. That picture on the left in 1987 is gel sequencing and Sanger-based sequencing, which was the way they were doing it when I started out in this field, and you actually had to do this very labor-intensive process of pouring gels and manually loading in each sequence. I don't know if anyone here has ever seen that or done that. It was very, very time-intensive. It was what they were doing at the start of the Human Genome Project, and they had people working 24/7 in centers across the country to try to actually get the volume they needed to complete the Genome Project. And it was sort of on the order of hundreds of base pairs a day. Jump ahead to 2012 or now, and now we have what's called next generation sequencing. Very, very different technology, very non-manual, very, very automated, and essentially much, much larger numbers of base pairs that we can get through a day, and we can do exomes and genomes. The actual sequencing part takes a matter of days. The prep part included takes a matter of weeks. So it's just a very, very different order of magnitude in terms of the amount of data that we can generate. And this is a graph, and the y-axis is the number of kilobases per day per machine, and the x-axis is the years, and you can just see how exponential the growth has been in the amount of data that can be generated and the amount of exomes and genomes from individuals that can be examined at any one time, either for research purposes or for clinical purposes. So it's really, really, really changed the way we think about the research questions, and it's really, really changed the way we think about the ethical challenges. And that's been really interesting and really where a lot of my passion and interest lies. So exome and whole genome sequencing use these next generation approaches to sequencing. And exome is the parts of the DNA that make up the proteins, and that's only about 1% to 2% of your genome. And I could give a whole nother talk about what the other 98% is, but I won't. And most but not all disease-causing variants and even risk increasing or decreasing variants are in the exome. So really, that's what people have focused on. It's a little bit easier in some ways, it's a little bit higher quality in some ways, and it's a little bit cheaper. In the 6 years that I've been here at Truman Katz, exome sequencing has been the focus, although that's starting to change and moving more towards whole genome sequencing, which is actually exactly what it sounds like. It's looking at the whole genome. And it allows researchers or clinicians or labs to look at variants not just in the coding regions for the exome, but also the non-coding regions where there are some really important changes and you can get a bigger picture. So these are both things that are happening right now in research. Exome sequencing is whole genome sequencing is really not happening in clinical care yet unless it's in the context of a research study, although that is and will be changing any day now, I would say. By the time this conference happens next year, I would suspect that whole genome sequencing will be available for clinical service in some settings. So the way I got involved in this is when I started here at Truman Katz, I had a project from NHLBI where I was being what I called the integrated ethicist, working with the Center for Clinical Genomics and Genome Sciences at University of Washington. And as a part of that, they actually did a study where they applied both exome sequencing and whole genome sequencing for the first time to try to solve a Mendelian condition. And it was really the first family study that used these new techniques, and they intentionally chose to study a rare limb malformation disorder called Miller syndrome. And this is the family that was studied, and they have given permission for this picture to be used. And what was so exciting about this project was that they actually were able to identify the mutations in the gene that actually caused Miller syndrome. And so it was an example of the potential success and power of this approach to solve rare unsolved Mendelian disorders. But this family actually had another sort of subphenotype where they actually had a lung condition that presented a lot like cystic fibrosis. And in fact, at one time, some of their clinicians thought it might be cystic fibrosis, but they couldn't identify two causal mutations in the family. And they had been quite ill with it, and they had been hospitalized quite a great deal for it. And in doing exome sequencing, without sort of intentionally trying to, and it was, backing up, it was unclear whether or not that lung phenotype was something related to their Miller syndrome or was in fact something else that was going on with them. And in the context of doing the exome sequencing, actually as part of the methodology of looking for the gene that caused Miller syndrome, they actually identified that this family had another mutation in a gene called DNAH5 that causes another rare recessive condition called primary ciliary dyskinesia, which is a lung phenotype where the cilia don't work properly, and the pulmonologist in the audience can correct me, but it presents frequently with a lot of similarities to cystic fibrosis. And so this was really important to the family because it was really a condition that was affecting them and affecting their lives. And it was an example of sort of a real incidental finding, an example of something we weren't looking for, but was something that was found in the course of the research that absolutely had clinical importance to this family. So from a sort of ethics standpoint, this was really interesting because it was really part of what we're going to have to struggle with on a larger scale as we do more exome and whole genome sequencing across settings, as I'll talk about in a second. So as part of my role in that study, I actually designed and conducted a parallel empirical study where we actually interviewed the two families that were involved in this study at different times in the process after informed consent and after they received results back. And I'm not going to present all of the data from that, but just briefly, the family was really challenged in thinking about what kinds of results they did and did not want to know when they could think about the range of all possible results. And this was before they got their results back. They really didn't believe that results would substantially impact their daily lives. They hoped that the result, cause of Miller syndrome would be found, but they still really wanted the option to receive all results across a range of categories and a range of possible conditions and risk factors. And they expressed that they really wanted control and options for choosing different kinds of results, for changing preferences over time about what results they wanted, for viewing results at their convenience and being able to ask questions over time as they process the information. And they wanted to be able to share the results with their healthcare provider. And again, they really wanted to be offered a range of results. And so these findings, while they were only on a very small number of families in a fairly new and novel study, really helped frame sort of a research agenda for what we've been working on for about 5 years since then, thinking about how can we facilitate allowing individuals to think about the range of results that might be identified and what they might and might not want, and maximize the benefit and minimize the harm from those kinds of results. And I think one of the most important questions that has come up, which I think is interesting because it's an intersection of sort of understanding the science and understanding the ethical issues involved, is thinking about, well, what results are people really going to have? What are we going to find? And I think, in the past, before research studies were done with sequencing, people didn't think we were going to identify very many results in the context of linkage studies and other kinds of genetic studies using other approaches. And so the answer from the large exome studies that have been done in the last couple of years is that it depends, which is, a really frustrating answer, but it depends on a couple of things. It depends on how you define or classify results. Do you define or classify results in terms of how useful they are, or what we call what their utility is? And even then, how do we define utility, and how do we define what's useful? Do we define them in terms of what's actionable? And a number of our colleagues actually think that should be the focus, something that I can do something about to mitigate or prevent disease in a short time frame. Or do you define them in a different way? Can I diagnose something that I might not know about otherwise? Can I predict an outcome? Can I modify my risk over a long period of time? Do I only return results that are highly penetrant? How do you think about those things, and how do you think about explaining those to individuals who have had exome and genome sequencing? It also depends what genes you look at, as I'll show you in a second. It depends who you look in. It depends a lot who you look in. So the results that we might find among this half of the room might be different than the results that we would find in this half of the room, especially depending on the demographic characteristics. It depends what criteria you use, and this is a great debate, as Steve and Lainey know well in our field, about how we're actually going to define criteria that we can sort of standardize across institutions and labs, and how many reviewers you have. There actually are some studies that show that it depends on how many different people you have studying it, which is true for a lot of things in medicine. And then I'm particularly interested in how we think about utility in kids. Do we think about just short-term medical utility, something that's going to affect a diagnosis or a condition that they might have during childhood very soon? Do we look more at long-term medical implications, including some conditions that they might develop in childhood, but they might not develop until early adulthood or later? Or maybe only conditions that they might only develop in adulthood. What are the risks and benefits of that information? As I'll talk about, we've talked about that one way in the past, and we're sort of starting to think about whether we need to think about that differently. Reproductive planning. Do you give kids information about carrier status when they're not likely to make the decisions using that information for some time? And broader life planning. So I'll give you some examples of those from our research in a moment. So just to give you a quick view into some of the data, there have been a number of studies looking in large populations about what results people have. So if you focus on a more narrow definition of utility, highly penetrant genes and variants that actually result in rather severe phenotypes, there is a study that was just submitted looking at what's called the Exome Sequencing Project 6500, which is 6,500 exomes from a range of studies from the National Heart, Lung, and Blood Institute, which is not that relevant to this discussion. And if you just focus on what the American College of Medical Genetics, I'll talk about this in a second, defined as their sort of most actionable genes, which was 56 genes, they found that 1.5% of European Americans and 1% of African Americans had a result that would be potentially offered for return in those categories. So that's not very much, although for those people, those results might be very important. When they expanded their criteria a little bit to 116 genes that they defined as medically actionable genetic disorders that may be undiagnosed in adults, and this has been submitted and was presented at ACMG earlier this year, it went up a little bit, 1.9% in European Americans and 1.2% in African Americans, but not that much. And then a study by Les Biesecker and his colleagues at NIH, which is called ClinSeq, looked in just under 600 people, and they looked just at cancer risk genes, 37 of those, because people might be very interested in those, and about 0.8% of non-Ashkenazi Jewish participants and 4.1% of Ashkenazi Jewish participants actually had returnable results, actionable results in those cancer risk genes. So again, you can kind of see that it depends on your definitions, how you look, and who you look in. But if you broaden your definition of utility to think not just about those highly penetrant, highly actionable things, we actually have conducted a study that was just accepted in the American Journal of Human Genetics, looking at 3 different categories of genes that are a little bit different than what we've usually thought about, but using very, very conservative criteria for how we define what the genes are and what the variants are that we are fairly sure there's substantial evidence that supports them actually affecting risk and affecting pathogenicity. So if you looked at genes for newborn screening conditions, and the good thing about newborn screening is that we really understand the biology very well, and we have very good databases about the variants and whether or not they're related to disease, and we also have very good population estimates in this country. So we looked at 39 newborn screening genes and looked at known pathogenic variants for those conditions, and when you look at those, just at carrier status, these people don't have the conditions, 41% of European Americans and 44% of African Americans carried at least one known pathogenic variant in those 39 newborn screening genes. So that's a very different, that's sort of the other end of the spectrum. When you look at a condition that's late onset and is a complex condition where there are lots of genetic and environmental factors involved, but again, about which we actually know a fair amount about the biology and the genetics involved, age-related macular degeneration, we looked at 17 genes for which there is clinical genetic testing available, and we looked again at things for which there was substantial evidence in the literature for known risk variants, and when you look at those, everybody's got them. 100% of European Americans have at least one, and 99.8% of African Americans have at least one. So again, different end of the spectrum, perhaps not that useful, you might argue, and we can talk about that, but different end of the spectrum. And when you looked at genes associated with medication response or pharmacogenomic genes, and we use a database called PharmGKB, which actually curates data on pharmacogenomic risk, looks at lab evidence, population evidence, and we use the highest level of criteria of causation. Again, almost everybody has at least one of those known variants. Now, almost everybody may not ever come in contact with those drugs. Some of them are chemotherapeutic agents, some of them are blood thinning agents, other kinds of things. But for the people who will come in contact with those drugs or may, that information is potentially very useful and might avoid adverse responses or not the response that the physician was intending. So everybody's going to have results of some kind. It depends on how you define it, which is, sort of a duh. Of course we all have results. But they're results about which we're not guessing. They're results about which we actually know something. And so it's really no longer a question of whether results of clinical or personal utility will be found. As a result, I argue that we need to shift towards thinking about how to interpret and manage different kinds of results and really manage results expectations and obligations of research participants, researchers, clinicians, and patients. And any analyses that we do of results and of genomes and exomes will be dynamic. Our existing databases, some of them are good and some of them are not, are very dynamic, and our knowledge is limited and we're learning more all the time. And our interpretation can be highly subjective and context dependent. And really our understanding of disease etiology and pathogenicity is really changing. And we're finding that we think we know that these changes in this gene cause this sudden cardiac death phenotype, and then we look in these big populations and it turns out that a much larger proportion of individuals may be walking around with these than we thought had long QT syndrome. So we really have to be careful and think about how we interpret these and how we understand them. So thinking about pediatric research, we have to think again about what are the obligations to offer a child's parents different kinds of results. So last year we talked about RET mutations for medullary thyroid cancer, where there's actually a very clear action to be taken. People often know they have a family risk of this, but sometimes they don't. Is that the kind of result that you would want to offer to a parent? It is on the ACMG list of genes. How about a BRCA1 mutation? Probably not going to be relevant until adulthood, and there's been some work by Ken Tersiak and others about whether or not adolescents should be tested for this. A KCNQ1 mutation for long QT syndrome, again, not likely to present until adulthood, although there are, I believe, some presentations in the late teen years. SCN1A mutation for epilepsy could be very, very useful for both diagnosis and for decisions about what treatment would be appropriate for a child presenting with epilepsy, and is actually done quite frequently as a part of standard clinical workup. Or a CFTR mutation that may not actually cause CFTR, but may cause some of the other phenotypes that are associated with mutations in the cystic fibrosis gene. And so I think one of the big questions is, does the duty to warn a child or a family potentially outweigh what we call the sort of right not to know, or the right of a child to make the decisions for themselves when they're adult about whether they want that information? And is this question, or is the duty to warn, the same or different for different kinds of results in different people? I think I'm as guilty of this as anybody, tend to sort of think about these things as equally applying to all results and all people in all contexts. And as I'll show you, I don't think that that's necessarily true, which unfortunately makes making policy much more complicated. Does the child have a right to access that information as an adult? At the end of the talk, I'll just give you an example of whether or not children actually should be allowed, even if we decide not to offer certain information to them as a child, if that information is being used by researchers, or Pearl will talk about this later in a biobank later, do they have a right to some of that information once they're old enough to make that decision? And how do we balance autonomy, beneficence, and non-maleficence? So just briefly, we are very lucky that Lainey's here. I just want to mention that the AAP ACMG guidelines that were written together for pediatric predictive genetic testing came out last year, and this was an update of sort of existing guidelines that had been placed but not updated for some time about genetic testing in children. And I just wanted to put these two quotes here, that decisions about whether to offer genetic testing and screening should be driven by the best interest of the child, and I think that's something that probably everybody at this conference would agree with. And then went on to say that predictive genetic testing for adult onset conditions should generally be deferred unless an intervention initiated in childhood may reduce morbidity and mortality. And I think that has sort of been something that people have been very comfortable with in the sort of clinical genetics field in general, that we wouldn't necessarily order a genetic test that was only predictive for an adult onset disorder in a child. But again, the challenge comes up when we're not ordering that test, but that information becomes available in the context of clinical sequencing that we've done on a child for a condition that actually is occurring in childhood. And around the same time, as I mentioned earlier, the American College of Medical Genetics came up with their guidelines for incidental findings reporting from clinical sequencing, which has been very controversial and much discussed, at least in our field. And essentially, just to summarize, they listed 56 conditions with what they called mandatory reporting, although they've revised this a little bit now, which were essentially those most likely to be verifiable by other diagnostic methods and amenable to medical intervention. So they were really focusing on that sort of actionable definition, and a sort of fairly strict definition of what actionable was. And they sort of, some argued, came up with a slightly contradictory conclusion to the AAP-ACMG conclusion, which said at this moment in the evolution of clinical sequencing, an incidental finding relevant to adult disease that is discovered and reported through the clinical sequencing of a child may be the only way in which that variant will come to light for the parent. So they were actually arguing that adult onset results should be returned in children because it had benefit to the parent, which I actually disagree with that as the primary reason for returning the result, and there's been a lot of discussion and debate about that. I'm more interested in whether or not offering or returning that result has any short-term or long-term benefit for the child, and it's usually the parent who's the broker of that decision. So, and then in April of this year, they released a sort of frustratingly vague statement saying that individuals would be allowed to opt out of secondary results, and they didn't explain how or when that would happen, and they didn't provide any information. And I have heard, and others may be able to clarify this, that they are working on it, so there will probably be more detailed guidelines soon, but they're no longer mandating return of results for any secondary results from clinical sequencing. And the labs are not completely following these guidelines. Some of them are and some of them aren't. So this has been, again, a topic of much debate in the field, and as a part of this, our group did a survey, online survey of genetics professionals, not just clinical but also research, members of the American College of Medical Genetics, the American Society of Human Genetics, and the National Society of Genetic Counselors, and we got just under 800 to respond, and we asked them what they thought. We asked them a lot of questions, which I'm not going into, but I just wanted to show you these. We asked them what they thought about this issue, about what we should do about results in children, and we also asked them questions about how that related to their practice. And 88% agreed that incidental findings about childhood onset conditions should be offered to the parents of a child who's undergone medical exome sequencing. But somewhat surprising to us, 62%, which was more than we were expecting, thought that incidental findings about adult onset conditions should be offered, not necessarily mandatorily returned, and in fact they didn't agree with mandatory return, but offered to the parent of a child who undergoes sequencing. And they also felt that 62% thought that carrier status results should be offered. But again, 20% did not think they should be offered. So this was interesting to us to sort of get a finger on the pulse of what a lot of the people in the field are thinking, and we have other data breaking it down by discipline and specialty within the field. And that paper came out 2 weeks ago. I think I hope I've sort of shown you that this issue about what results we're going to find, what results return, kind of creates this elephant in the room. I think we now have to sort of think about and talk about what we're going to do about these results and the ethical framework about how we're going to think about the potential benefits and risks of the results, both in clinical sequencing and in research sequencing. So I actually paid for a license for this cartoon because I like it so much, and I think about it every day now. And the guy was very nice about it when I told him I was going to show at this conference. So we are doing a study that's a R01 study funded by NHLBI as part of the larger Return of Results Consortium sequencing sort of program that they have, which is called the My46 study. And I'm not going to go into My46 today. You can look at it online at my46.org, but it's essentially a web-based tool for allowing individuals to set preferences about what kinds of secondary results they want to receive, and actually testing receiving those results online with follow-up from a genetic counselor compared to sort of standard of care, which is getting them from a genetic counselor. But I'm not going to talk about that part of it today. I'm going to talk about what parents said about results. And we recruited about 150 participants who were already enrolled in existing studies of Mendelian and complex diseases and whose exomes had already been sequenced as a part of that research. And as I said, they were allowed to choose from a range of different results that they wanted, and then they're being randomized to receive results through these two different methods. And this is just to flash up who these people were. About 60% were parents of minors who we talked to, a range of different phenotypes. I think those phenotypes are important to some of the results I'm going to show you. We mostly had women who were interviewed and responding, and the average age was 45 years, and they were predominantly self-reporting as white and higher SES. So we'd asked the parents about what they thought were the benefits of secondary results for their affected child. And several of them said that they thought that it would help them prevent future conditions. So one cystic fibrosis parent said, knowing things that could be enlightening towards preventing or correcting lifestyles, anything that would make her life easier. Another parent of a child with a brain malformation disorder thought that secondary results would help guide or ease management, and said, I want to know everything that's going on so I can know how to treat it or what the doctors to see or know how to relate to him. A couple said they really wanted the results for their or their other children's future reproductive planning. A parent of a child with limb malformation said, I'm curious if what she has, mostly if she would be able to pass it on to her children. That's a big one. And quite a number of parents brought up reproductive planning as both related to the condition and related to secondary results as something that they would explicitly want. Many of the children, as you probably saw from the brief slide on the phenotypes we studied, have some form of disability. And a number of parents talked about secondary results relating to the planning for the long-term future for their disabled children. This one parent said, well, obviously there's going to be a time in our lives when we're not around and our son is still alive. So if we have some insight to what his future medical needs might be or some things to watch out for, we can advise survivors to keep an eye on this, including healthcare providers, and family members. So really focusing on what to tell people to look out for. They use interesting metaphors when they're talking about this, and this one other brain malformation parent talked about sort of tea leaves and crystal balls, and said this somewhat tongue-in-cheek in the context of the actual interview, but was serious about it. Our son is nonverbal, so we have the added trick if he can't tell us how he's feeling. So if he would develop symptoms, we would have no idea. He's a bit of a puzzle. We're reading tea leaves right now, so if there is diagnostic information we can get to tell us stuff that he can't tell us, that's to our benefit. Because it's for a dependent child, and I would really have to think about, estate planning and his future needs when we're not here. I think we would really want to know everything. We could use the help of a crystal ball, I guess. So they look at the future, and they feel like they don't know what's in store for their child in any way, both related and unrelated to their condition, and they want information that will help guide planning, care, prevention, and treatment, not just for them, but for the people who are taking care of their child who at least to some degree lacks some capacity. A number of parents talked about the potential benefit of both primary and secondary results to the siblings of an affected child. Several talked about information for siblings' health, and this one parent said, as far as offering a heads up, since he's a direct sibling, he could have the same thing, so I guess that would be a benefit if there's something we need to look at for him. And that was also motivating them to participate in research. And again, as I mentioned, they talked about informing siblings' future reproductive choices. And this parent of a child with autism said, I think we're interested in the information that we can pass on to our daughter and our son, affected son, if they're potentially going to have a family. So they're thinking about the long-term implications as well as the short-term implications. And in general, their attitude was that they really, as I'll show you in a second, they really felt like whatever the results were, they could handle it, they could cope with it, and they really would rather receive results and saw information as good. Again, in this particular population of people that we talked to. And this mom said, I guess it makes me a little nervous, everything we've gone through, I just don't want her to have anything else, but I also feel like if there was something that we could prevent or make better, I would want to do that. So I guess I feel pretty relaxed. Whatever, we've made it this far, we've made it through all those things that have gone wrong, so it's like bring it on, we can handle it. And there were several parents who sort of expressed that same sentiment. A couple of parents talked about the child's role in decision making and talked about how they sat down as a family to talk about what they would and wouldn't want. And one mother of a child with autism actually talked about partnering with her child and said, I think there's a possibility for me partnering with my son in his own care with information about himself since science is interesting to him. So that was very interesting and important to us. One cystic fibrosis parent said that her child's view had been very different from what her own view had said, and basically said, I want to know things about me so I would know them when I grew up and got married and had kids. That's kind of where her mindset is, about her future, and I hadn't even thought about it. So having that conversation with her child actually influenced what she chose to receive on behalf of her child. And then another parent talked about preparing her child for adulthood and taking responsibility for their own health and said, the opportunity to try and prevent or reduce the risk later in my son's life or educate him, since I can only tell him so much, he's going to have to use that information, make sure he always goes to his doctor for his checkups. And that's consistent with some results from the literature about returning other kinds of genetic results that are risk kinds of results. So this is the preference grid that they saw, just to show you that you can't really see this, but they had a range of different disease categories and carrier status, medication response, and ancestry that they could choose what results they wanted to receive. And just briefly, I want to tell you, 80% selected all possible secondary results, and a slightly larger proportion of parents than adults selecting results for themselves chose them all. The average number of result categories they refused was 1.8 in parents and 3.5 in adults, so adults were refusing more kinds of results for themselves. And in parents, the most commonly refused secondary category was ancestry, whereas in adults it was brain and nervous system, and so we're analyzing more of the qualitative data about that right now. And interestingly, thinking about parents refusing results for their child, one said that their child should decide about carrier status when he reaches adulthood and said, I didn't really feel like it was any of my business. I thought it was more his thing. So that's kind of consistent with thinking about how we think about deferring that to adulthood. And then this other parent of a brain malformation said no to cancer as a category and said, I just wanted to let him be a kid and not have to worry about that. So those are the kinds of reasons that parents think about why they would not want to receive results, though again, that was the minority of people in our study and from the populations that we studied. So in summary, parents really want results both of short, in our study and the kinds of phenotypes we studied, which is an important limitation, really wanted results of short and long-term clinical utility for management of their child's health, prevention and mitigation of future health risks, and promoting healthy behaviors and responsibility. They really see getting secondary results back as part of being good parents and as part of long-term life planning, and they use good parent in some of their quotes. And they really want to promote risk awareness for their children's current and future caretakers, and they talk about estate and long-term planning for children who have significant disabilities. They talk about health benefits for siblings and that being sort of a driver for some kinds of results, so they see the benefit outside of the individual child, which we can talk about the potential pros and cons of whether that should affect decisions about returning results. And they are explicitly interested in results for reproductive planning, even though obviously that doesn't have a short-term clinical benefit or isn't short-term actionability, both for the affected and the unaffected siblings. They really want to involve their child in decisions as appropriate. They want results, but they want the ability to choose and defer some results until later. They may view results through an optimistic lens. I think that's an important finding here, that they see, in other quotes, they sound more realistic about it, but they are very hopeful that research will lead to positive things for their child, which I think is an important follow-on to what we were talking about yesterday, about how we talk about integration of research and clinical care. They really acknowledge almost to a person that they might get worried or anxious about the results, but they really do also say at the same time that they think they can work through it. And they think the benefits outweigh the potential risks and harms. And I think it's important that the perspectives may differ across pediatric populations, and this is one subset of populations. We need to talk to other kinds of both disease populations and healthy populations to look at the perspectives and think about the benefits and risks across populations. So finally, I just want to say an example of the emerging challenges of what happens with exome and whole genome sequencing in pediatric research. There was a press release just about a month ago that Autism Speaks and Google have decided to put 10,000 autism genomes into the Google Cloud and make it publicly available for research to try to promote and stimulate research into autism. They're planning to put up both genomes and phenotypic data, and it's funded by Autism Speaks, which is one of the national advocacy groups. But they are not currently offering primary and secondary results to individuals who are enrolled in these studies. So it's interesting, they're putting the information on the cloud and making it available, but they don't have the resources or the structure to actually offer any kinds of results to the families who are enrolled in these studies. And when this came out, the Autism Speaks co-founder, Bob Wright, was quoted as saying this announcement represents an unprecedented intersection of business, science, and philanthropy that will drastically accelerate the pace of autism research, very optimistic. But at the same time, in the autism rights community and autistic self-advocate community, Amy Sequenzia, who's a fairly well-known autistic self-advocate, said, this should not be an excuse to use our genetic information for the profit of others. I notice there are no plans whatsoever to use profits for better services. So there are issues about consent, there are issues about use, there are issues about what the primary goal is. I think this also relates again to our discussion yesterday about what happens with data from research, even if it is being used first for clinical benefit potentially or for learning, but also examples about return of results. If we're making information available to everyone, what obligations in research do we have to make at least information we understand well available to participants and to pediatric participants? So I think most pediatric research will include exome and whole genome sequencing, and we have to think about these obligations and think about how we manage results and think about whether children should have the ability to access results when they reach adulthood, especially if they're shared in places like the Google Cloud. Does it matter if the children are sick or healthy at the time of the research? I think maybe it does. And does it matter if primary results are being offered for the condition that's being studied? And I think that also raises some really important questions. And do we need to think about or rethink the benefit and risk ratio of results? I think we need to think about, can we do harm in some situations by not offering some results? And how can we better explain the benefits and risks of specific results at different ages and time points, because they may not be the same across all ages and all populations. And then I think we absolutely have to assess and track the benefits and harms over time. I and others can stand up here and present our small studies and hypothesize and speculate, but I think we really need data in order to do a good job in thinking about how we actually should implement this in the best way possible. And I work with a lot of wonderful people. This research is very interdisciplinary, and I couldn't do it without many people, including a lot of the research staff here at Trim and Katz. And the data I presented from the exome sequencing project is an even larger number of people, and without all of those people, none of this would be possible. Thank you.